10 of the House of Commons Standing Committee on Health. Just a safety reminder to ensure that your earpiece is not too close to the microphone, as it can cause feedback and potential injury. In accordance with our routine motion, I'm informing the committee that all remote participants have completed the required connection tests in advance of the meeting. Pursuant to Standing Order 108 Sub 2 and the motion adopted on November 8th, 2023, the committee is resuming its study on the opioid epidemic and toxic drug crisis in Canada. I'd like to welcome our panel of witnesses here with us today. As an individual, Dr. Nathaniel Day, Provincial Medical Director, Addiction Alberta Health Services, appearing by video conference, the British Columbia Association of Chiefs of Police, represented by Fiona Wilson, President and Deputy Chief, the Vancouver Police Department, the Canadian Association of Chiefs of Police, represented by Rachel Huggins, Deputy Director and Co-Chair, Drug Advisory Committee, and the Royal Canadian Mounted Police, Dwayne McDonald, Deputy Commissioner, and Will Ing, Assistant Commissioner. Welcome to all of our witnesses. Thank you for being here. I'm sure you've been advised that you have 5 minutes for your opening statement. And we're going to begin with you, Dr. Day. Welcome. You have the floor.
Thank you, Chair. Thank you for the opportunity to speak to your distinguished committee today. I'm Dr. Nathaniel Day. I'm the Provincial Medical Director of Addiction for Alberta Health Services. I am also the person who designed and with our team implemented Alberta's virtual opioid dependency program. I was a member of the Minister's Opioid Emergency Response Commission in Alberta under the Notley government and was the co-chair of the Recovery Expert Advisory Panel for Alberta's current government. I will briefly summarize some of the actions we have taken in Alberta to respond to the current phase of the opioid addiction and overdose crisis. I will raise things that I think are successful and could be replicated. Of course, a long-term problem requires long-term effort in order to see maximal benefits. As recently as 2016, Alberta, like all jurisdictions, struggled to meet the needs of people with opioid addiction living anywhere not immediately local to a bricks-and-mortar opioid dependency treatment program. All jurisdictions have struggled with this problem. I proposed a new approach that provided virtual care, now expanded to every community in Alberta. To our knowledge, we were the first program to ever look at exclusively virtual care with no in-person component. We collected data on outcomes for our patients, which has been published in the literature. By providing virtual service, we were able to reach people who had never been reached previously. We have served people in 331 different communities, villages, cities, hamlets, all across our geography. Since 2018, we have not had a wait list for services. If you need help today, you get help today. Right now, there are people in Alberta who are certainly calling in for help. Our allied health team starts an assessment. Our physicians work on shift 24 hours per day to assess and treat. Prescriptions go out to pharmacies closest to the patient, including delivery to remote Indigenous communities. Because we use virtual tools, we can also support new places where people with opioid addiction are. Our objective is to reach anyone who needs our care, wherever they may be. For example, we have found that police, like all frontline workers, want to help the people they encounter who suffer from addiction. Police in all jurisdictions have people who use opioids who are arrested for any reason, who, while waiting to see a justice of the peace, are going into withdrawal or are at risk of going into withdrawal. In Alberta, when a person is under arrest, they can be connected confidentially using the same rooms that a person would use to speak with a lawyer, to get a healthcare intervention to manage their withdrawal, and an invitation to continue with us if they choose. About 10% of those patients are filling prescriptions in community 90 days later. We have supported the province of Alberta's encampments response. We provide support to people in shelters, low-barrier housing programs, and supervised consumption sites, essentially any place a person is who wants service. Alberta is expanding access to bed-based services. Government has funded access to bed-based treatment spaces that were previously private. Government has eliminated the copay for addiction treatment. Alberta's government has also announced 11 new recovery community treatment programs, 2 of which are now in operation. The others are in various stages of planning or construction. Alberta is working with provincial corrections to expand meaningful treatment for people with addiction who are incarcerated. Alberta has legislated licensing and accreditation standards for addiction service providers. This ensures that any Albertan who accesses our system of care receives evidence-based quality services. We have a gap medication program that gives no-cost provision of Suboxone, Sublocade, or methadone to anyone with a healthcare number with no application and no delay. There is much more that we could talk about. I will conclude with this. We would not be in this situation if our communities and families were as healthy as they could be. I recommend that this committee support only initiatives that will improve community and family wellness. It is important that all people with addiction, which touches all Canadian families and communities, be offered hope. Hope is, in my opinion, the antidote to stigma. Hope is powerful, and the evidence shows that when it sets in, increases positive outcomes. Thank you.
Thank you, Dr. Day. Next, from the British Columbia Association of Chiefs of Police, Fiona Wilson. Welcome to the committee. Ms. Wilson, you have the floor.
Thank you. Good afternoon, everyone. In my role as president of the British Columbia Association of Chiefs of Police, I'm honored to share with the House of Commons Standing Committee on Health our experience as police leaders with decriminalization in British Columbia. The decriminalization exemption was issued under Section 56(1) of the Controlled Drugs and Substances Act by Health Canada, and it took effect over a year ago on January 31st, 2023. The exemption is part of a 3-year pilot that aims to take a health-led approach to substance use as opposed to one led by the criminal justice system. In British Columbia, we know all too well the severity of the toxic drug death crisis. Yesterday marked 8 years since a public health emergency was declared in British Columbia on April 14th, 2016. Since that time, tragically, more than 14,000 British Columbians have died from accidental overdose. We've seen the crisis have the greatest per capita impact on rural communities, including those in northern British Columbia, on Vancouver Island, and in the Cariboo. In many of these rural communities, the crisis can be double or triple the provincial average. Sadly, the highest per capita impact has been in Vancouver Centre North, which includes Vancouver's downtown east side. Here, the stark reality is that the overdose crisis is more than 12 times the provincial average. We recognize that the crisis has had an especially devastating impact on Indigenous people in British Columbia. Alarmingly, Indigenous people are 6 times more likely to be impacted by the crisis than non-Indigenous British Columbians. In recognition of the magnitude of this crisis, police leaders in BC supported decriminalization and taking a medically led approach to substance use. At the heart of it, police agree that people should not be criminalized as a result of their personal drug use. In terms of police data, across British Columbia, there's been a more than 90% reduction in drug seizures at or below the 2.5 gram threshold. Based on these results, I'm confident that frontline police officers are doing their part to implement the decriminalization exemption and to support a health-led approach to substance use. However, the implementation of decriminalization has not occurred without criticism or concerns. As police leaders, we were unequivocal about the need to prevent unintended impacts on community safety and well-being, especially for youth. The British Columbia Association of Chiefs of Police clearly identified some of those potential consequences prior to the submission of the exemption request, both orally and in writing. These serious concerns included, but were not limited to, the matters of public consumption in licensed establishment and other places such as cafes and restaurants, and impaired driving. However, the implementation of decriminalization occurred before more fulsome restrictions on public consumption and problematic substance use could be adopted. While the vast majority of people who use drugs do not want to do so in a manner that negatively impacts others, there have been several high-profile instances of problematic drug use at public locations, including parks, beaches, and around public transit. In addition, there have been concerns from small businesses about problematic drug use that prevents access by customers or negatively affects operations. To address some of these concerns, after significant advocacy on the part of police in BC, 3 additional exceptions were added to the exemption on September 18, 2023. In addition, the province of British Columbia has taken significant steps to enact legislation that would prevent problematic substance use that negatively impacts community members, especially youth. However, before this legislation came into effect, a BC Supreme Court injunction was granted based in part on the Section 7 charter rights of people who use drugs. Given the scope of the crisis, it is apparent that decriminalization is only one strategy that must be part of a broader, multifaceted response. Additional strategies include increased efforts in the area of education, prevention, treatment, and the provision of enhanced health services to communities across BC. While much work is occurring in these areas and significant investments of public resources have been made, it's clear that while decriminalization was able to come into effect in a relatively short time frame, these other strategies will take significantly longer to achieve and implement. While working towards better health outcomes for people who use drugs, there must also be consideration of the needs and well-being of the broader public. I believe that other jurisdictions that have implemented or considered decriminalization only to later abandon it have done so because of unaddressed and unintended impacts on community safety and well-being. Thank you.
Thank you, Ms. Wilson. Next, from the Canadian Association of Chiefs of Police, Rachel Huggins. Welcome to the committee. Ms. Huggins, you have the floor.
Thank you. Distinguished members of this committee, I'm pleased to have the opportunity to address you today on this very important issue. It's important to begin by noting that law enforcement agencies across the country acknowledge that the opioid crisis is a public health issue. While police have a critical role to play in terms of preventing illicit drug distribution, curbing supply, and safeguarding communities, we recognize and understand the need for a comprehensive approach that addresses the social determinants of health. This requires coordinated efforts across government, healthcare, the justice system, police, and community organizations. In July 2020, the Canadian Association Chiefs of Police called for a broad societal response that includes prevention, education, support systems, and access to treatment for those affected by drugs. We also supported the decriminalization of simple possession of illicit drugs as an effective way to reduce the stigma of substance use disorders, reduce public health and safety harms, and divert individuals with substance use disorders away from the criminal justice system. As you heard from my fellow co-chair of the CACP Drug Advisory Committee, Deputy Chief Fiona Wilson, our early experiment with formal decriminalization for simple possession of illicit drugs has had some unintended but not completely unexpected consequences. Preliminary results of this pilot project has proven what police leaders have stated from the beginning. Decriminalization of drugs for personal use is not one part of a system. It has to be part of an integrated, health-focused approach to address the opioid crisis and toxic drug supply. Today, the CACP reaffirms that its commitment for a health-centered approach to the drug issue and that the opioid crisis and that addressing the opioid crisis include the decriminalization of possession of illicit drugs. Sorry, just 1 second. Sorry about that. In the past 4 years, important procedural and legal reforms, as well as training, have been implemented. These have led to significant shifts in police and public perception about substance use disorder, as well as a decline in simple possession charges, thereby reserving criminal sanctions for the most serious circumstances. Decriminalization is about preventing the unwanted criminalization of personal substance use, creating a continuum of care that ensures persons who use drugs are better connected with health supports, and finally, third, allows the police to use and focus on serious illicit drug trafficking and production offenses. The pilot project implemented in British Columbia succeeded in achieving the first goal, which is procedurally and fiscally and easy to attain. Creating a continuum of care is much more challenging, as well as resource intensive. But the successful achievement of goal number 1 depends on the successful implementation of actions to support the achievement of goals 2 and 3. From a police perspective and police leaders, we see the importance of the critical importance of having the appropriate health and social structures in place before proceeding with changes to legislative frameworks that would formalize the decriminalization of simple possession. In conclusion, from a public safety perspective, Canada's police leaders believe that the success of any strategy in relation to the ongoing crisis of toxic drug supply should be measured based on its ability to improve health outcomes, reduce the impact of organized crime, address the proposed crime and public safety issues that result from unaddressed substance use disorders. The CACP believes that any strategy that is considered must be medically led, be based on empirical medical research, and provide increased health connections with medical professionals for people living with substance use problems. Thank you.
Thank you, Ms. Huggins. And finally, the Royal Canadian Mounted Police. You have 5 minutes in total. I'm not sure whether it's Mr. McDonald or Mr. Ng or whether you're going to split it, but you have the next 5 minutes all to yourself.
Thank you, Chair. Good afternoon. I'm Deputy Commissioner Dwayne McDonald, the Commanding Officer of the British Columbia Royal Canadian Mounted Police. I oversee over 10,500 employees, of which 6,800 police officers. We deliver municipal, provincial, and federal policing throughout BC. I would like to acknowledge that I'm joining you here today from our headquarters that is situated on the unceded territories of the Katzie, Kwantlen, and Semiahmoo First Nations. And I'm joined here by Assistant Commissioner Will Ng. He's our Criminal Operations Officer for British Columbia, and he serves as a single point of control and coordination of all investigative intelligence and specialized RCMP resources within the province of BC, ensuring alignment and enhanced delivery to the municipal and provincial contract partners. Thank you for giving us the opportunity to speak today. We're here to provide perspective and information about the impact the opioid crisis is having on policing for the RCMP in British Columbia. I'll explain our role, our training, our challenges, and some recent investigative findings. Since 2015, the RCMP have been grappling in British Columbia with the alarming rise in overdose deaths, fueled by the increased prevalence of fentanyl in the illicit drug supply. This crisis has not only claimed thousands of lives, but has also left a profound impact on our communities. Since the declaration of a province-wide health emergency in April of 2016, over 13,000 lives have been lost to toxic, unregulated drugs in British Columbia. This is a crisis that knows no bounds, affecting people from all walks of life and communities across the province. Indigenous communities in BC have borne a disproportionate burden of the crisis, facing higher rates of opioid addiction, overdose, and death compared to the general population. Persons with mental health disorders or poor mental health are also overrepresented among those affected by the opioid crisis. It's clear that this is not just a law enforcement issue. It's a public health crisis that demands a compassionate and comprehensive response. As you are all aware, as of May 31st, 2022, BC became the first province in Canada to receive an exemption from Health Canada under subsection 56(1) of the Controlled Drugs and Substances Act, which decriminalized the personal possession of illicit substances. We are now in our second year of the exemption, which is valid until January the 31st, 2026. The BC RCMP continues to support our partners and stakeholders as we all work through the implementation of this exemption. As a police agency, our role is to redirect people in possession of small amounts of certain illicit drugs away from the criminal justice system and towards health and social services. The RCMP continues to support all efforts to ensure that an overdose emergency is dealt with as a health and medical emergency. Emergency medical dispatchers assessing calls no longer call for police assistance in every drug overdose emergency. Police are only notified in overdose calls in circumstances where the situation is believed to be dangerous to first responders or members of the public, or for suicide attempts, whether drug-related or otherwise. It's crucial to note that drug trafficking remains an offense under the Controlled Drugs and Substances Act, and the RCMP is committed to investigating and prosecuting such offenses. Additionally, the RCMP prioritizes upholding the rule of law and ensuring the safety and security of the communities it serves by targeting violent offenders, deterring youth from joining gangs, and combating gang-related violence resulted from the drug trade. Efforts also include dismantling drug production labs and curbing cross-border trafficking, including importation of precursors. To support the implementation of the exemption and ensure consistent enforcement, the RCMP collaborates with the BC Ministries of Mental Health and Addiction and Public Safety and Solicitor General, as well as our law enforcement partners to provide training and resources to frontline officers. We've equipped our officers with the skills and knowledge necessary to navigate the complexities of the exemption and respond effectively to overdose emergencies. However, challenges persist. Despite the progress made, the management of public drug consumption following decriminalization remains a concern. Additional legislation is needed to address public consumption in non-exempted areas. We're actively monitoring the provincial government's effort in this regard, and we also continue to work with our cities and our Indigenous communities to address public safety concerns surrounding the unintended impacts of public consumption. The diversion of safer supply into the illicit drug trade also presents an emerging concern that requires forthright attention. Through ongoing investigations and collaboration with health authorities, we are working to better understand and address this issue to prevent further harm. Efforts are underway to improve our data capture and our analysis with the objective of developing a clearer understanding of this issue. Furthermore, we are currently working to develop training and education tools to help support our frontline officers recognize diverted safer supply. We also recognize the frustrations and challenges felt by our Indigenous communities who continue to bear a disproportionate burden under the opioid crisis. As partners in this fight, the RCMP is committed to working alongside Indigenous communities and agencies to develop and implement long-term strategies to address the root causes of drug addiction. We will also continue to hold accountable those who traffic drugs in these communities. In closing, I want to reaffirm the RCMP's unwavering commitment to tackling the opioid crisis here in British Columbia. We will continue to partner with government agencies, communities, and stakeholders to save lives and bring an end to this devastating crisis. Thank you for the opportunity to address the committee today. Myself and Assistant Commissioner Willing are available to answer any questions you may have.
Thank you very much, and we're going to go right to questions now, beginning with the Conservatives. Ms. Goodridge, please, for 6 minutes.
Thank you, Mr. Chair, and I want to thank all our witnesses for being here today and sharing on this important issue. I'm going to start out to Dr. Day. It's spectacular to have another Albertan here in Ottawa. One of the things that I have found is truly revolutionary in the world of addiction treatment is what Alberta's been doing with the virtual opioid dependency program. And I was wondering if you can go into a little bit more detail exactly how it works.
Yes, happy to do that. So the way that it works today in Alberta is, for example, if a person were at home and they were concerned about their opioid use, or maybe they'd ran out of their supply of drugs and they're in withdrawal, they can just call directly to a toll-free number, 1-844-383-7688, and they will get immediately connected with an allied health team member who will start to explore their situation. In Alberta, we have the benefit of a single medical health record, so we're able to see all of that person's health records from their hospital visits, previous overdoses, things like that. And then that person, once they complete that assessment with our allied health team, is almost immediately, it depends on how many people are phoning at one given time, but usually in not less than 15 minutes are connected with an addiction specialist who can then walk through what their treatment options are. and then prescribe a pathway forward for them to start evidence-based treatment medications. The prescription is sent to the pharmacy closest to where they live and or work as their preference is, and then that person can start right that day with treatment. And our team, of course, will follow up with that person, later that day or the next morning, see how they're doing, and we adjust the care from there.
So then what would happen if that person was, say, in a rural community like Janvier and about an hour and a half away from the closest pharmacy? What would happen to someone like that?
Yeah, so that is a challenge. We have many communities in Alberta that are rural remote and that have more challenging access to a pharmacy. So, for example, we're in your riding in a fly-in community. We've been working with the local health teams in that Indigenous community in order to have a supply of medication stored there on site securely, so that we can actually send the prescription to that nursing station, and the medications can be provided to that person as needed. Further, we're also working in Alberta to address this problem by enabling our paramedic teams to be able to carry evidence-based treatment medications as part of their kit, so that we'd be able to actually connect with our integrated health teams in the EMS world to bring the treatment right to that person.
I think that's truly revolutionary, and I know that required an exemption from Health Canada to even make that possible. Are there any other stopgaps you might have when it comes to Health Canada being in the way of you guys being able to expand this amazing service?
Well, to be honest, we started working with paramedics about 4 years ago. Unfortunately, we discovered that our work was illegal because at that time paramedics were not allowed to carry Suboxone or Sublocade in their kits. We weren't aware of that, and our paramedics weren't aware of that either. And actually, we were presenting some data on how well it was going when it was brought to our attention that we actually couldn't do what we were doing. Unfortunately, it's taken several years to get the change that's just recently, just in the last couple of months, allowed us to now move forward. And we're looking forward to being able to announce and implement in just a few weeks from now a province-wide program.
Thank you for explaining that. And I think that just highlights how challenging the bureaucratic mess of Health Canada can be. You did something that is truly revolutionary, getting Suboxone, Sublocade, absolutely evidence-based treatment modalities into communities using innovative solutions, and yet the bureaucracy says that it can't happen, and it took years to get that. So I guess my next question is, can you walk us through what the OPD would look like in Alberta Corrections?
Yeah, so in Alberta Corrections, we of course continue people who are on evidence-based treatment medications after they're arrested. We also will start people on treatment medications. Unfortunately, Canada's largest correctional facility is in Edmonton, the Edmonton Remand Centre, and its average length of stay is about 2 weeks. And what we were finding is that there were a large number of people coming in who were not able to start treatment right away, and the wait time to get treatment was as long as 4 to 5 months. So you can imagine that many people were coming in, were not able to start treatment, and then were released before they had access to treatment, which is a problem. So today, the way that it works is that a person goes in, they're immediately screened for opioid use disorder. They're able to provide a toxicology screen to support that. We do a video recording and connect that with our virtual opioid dependency team, and that person is now able to be assessed and initiated on treatment. I think the average is now 0.9 days from arrival, and we've completely resolved the wait list problem there by using technology.
Thank you, Ms. Goodrich. Next, over to Dr. Hanley, please, for 6 minutes.
Good day, everyone. Thank you to all the witnesses for appearing, and for the learning. I want to echo Ms. Goodrich's congratulations on the virtual care program, and I do think there's a lot for the whole country to learn from the successes there, Dr. Day. But I'm going to focus on other areas. A new paper out I think yesterday or today in the Canadian Medical Association Journal shows that in 2021, 1 in 13 deaths amongst people under 85 in Alberta was opioid related. I'm sure you're familiar with the paper, but for Albertans aged 20 to 39, incredibly, opioids accounted for 1 in every 2 deaths. And in some of the graphs in the article, the differences between Alberta and the other provinces, frankly, quite alarming. According to the article, towards the end, it says the burden of premature death from accidental opioid toxicities in Canada dramatically increased, especially in Alberta, Saskatchewan, and Manitoba. And these all suggest that Alberta is outpacing the rest of Canada when it comes to opioid-related premature mortality. From what I've seen, the 2023 data do not look any more reassuring. At the same time, that contrasts with, I would say, quite a positive note struck recently by your Premier, who said, over time, far fewer Albertans have lost their lives to addiction in our province, and many drugs had their lowest mortality on record. I know she's referring to decreases in other areas apart from illicit opioids, but the death rate from toxic illicit opioids by far eclipses all other causes and continues to rise. So all to say, when we have 6 Albertans dying per day, and when aspects of the full spectrum of approaches are being pulled back at the same time, perhaps you could summarize and maybe justify the approach that Alberta has taken. And how is the Alberta experiment going so far?
Thank you for that question. Alberta is, along with British Columbia, so if we look at the overdose crisis overall and the number of fatalities, British Columbia has the highest rate per 100,000 population. Alberta comes in second, and Ontario is third in Canada. And certainly, the arrival of fentanyl and carfentanil in our jurisdiction does not go unnoted. And none of us are happy with the number of fatalities that are happening because of fentanyl and carfentanil usage. That being said, the reality is that we have an obligation, and so I view my obligation in Alberta Health Services to ensure that we're building the best possible treatment system that we can, that's accessible to people when they need it, so that they can move along the continuum of care and receive evidence-based care. Alberta, I think, unfortunately, part of the story of what's happening in Alberta has not been narrated by Alberta. And so, for example, in Alberta and previously, as I was looking at transcripts for this committee, Alberta does have exactly the same number of supervised consumption sites today as it had 6 or 7 years ago. Alberta recently, just last year, opened 6 narcotic transition service sites that provide hydromorphone by injection or oral under supervision. So those medications cannot leave the site. And those sites are intended to help people with the most extreme form of opioid addiction and the most negative consequences of it. Furthermore, Alberta, as an example, distributed nearly 250,000 naloxone kits last year. So there are a lot of things that are happening in the harm reduction space that don't really make it to the front pages. I wouldn't say that Alberta is not investing in or working on those areas as well. I think where Alberta perhaps is different is that Alberta is trying to implement a recovery-oriented system of care where a person who enters care at a narcotic transitions service site or in a supervised consumption site is encouraged, and there's work done to try and connect that person with treatment supports going forward.
I may have to interrupt you at that point, and thank you for that. Now, I would love to get perhaps more solid data, and perhaps you could help to provide that. My understanding is that Alberta has about half the number of supervised consumption services than it did prior to the pandemic. We had the closure of Arches and other supervised consumption sites. I believe my colleague has talked about this closure in Lethbridge, for example. There's also resistance to acknowledging that inhalation is a primary mode now of illegal drug use, that Alberta has resisted this. So perhaps you could talk about when the minister of mental health and addictions in Alberta talks about strong outcomes for Albertans on the path to recovery. Can you talk about outcomes for Albertans who are maybe not yet on that pathway to recovery?
Yes, I'm not sure that I can speak to outcomes of people who aren't engaged in the health system, in that it's very difficult to measure that. To your comment, there was a supervised consumption site in Lethbridge run by a not-for-profit society that was closed, but the services were immediately transitioned to a site that's under my supervision. It's called an overdose prevention site, so it's not technically a supervised consumption site, but it has booths. It's operated by our public health care system. It's located in the parking lot just outside of the shelter that's in Lethbridge. The shelter, which is operated by the local Indigenous community, actually. In terms of outcomes overall, I can say this with a surety, that whether it was the previous government or the current government, all efforts are looking towards improving outcomes for Albertans. And every initiative, every project that we have is intended to make our system better, more comprehensive, with less gaps that will allow people who need the services to receive them.
Thank you, Dr. Day. Suite, Monsieur Thériault, pour 6 minutes, s'il vous plaît.
Mr. Thériault, you have 6 minutes. Thank you very much, Chair. I will speak slowly in case some of our witnesses don't necessarily master French completely. I'd like to speak to the police representatives first. From what I understood in your testimony, your 3 associations, decriminalization of simple possession has had more positive impacts than negative impacts in our fight against the opioid crisis and overdose cases. Am I wrong? Am I mistaken? I'll start with the RCMP, and then perhaps Ms. Higgins, and then Ms. Wilson.
Thank you for the question. So it has had positive effects. So that is what we're seeing with the numbers. There has been a significant decrease in criminalizing individuals for simple possession offenses. And it also gives police the opportunity to divert those individuals into those pathways of cares, to get them whatever support or additional resources that they require from a community perspective. I think that the part is...
Merci. Je voulais...
Thank you. I didn't necessarily want a very detailed response. I just wanted to see if the 3 of you all share the same opinion. So, Ms. Wilson, do you also agree with what Ms. Higgins just stated?
I'm sorry, I apologize. I only just turned on my translation and I did not understand the question.
Mr. McDonald.
Mr. McDonald, then?
Yeah, pardon me, I'm in the same situation as Deputy Chief.
Peut-être faire une petite question d'ordre, là.
Perhaps I could just raise a point of order. Could you please let the witnesses know what they need to do in order to be able to hear the interpretation? And then I would like to be able to start over and ask the question again. Yes, of course you won't be at a disadvantage. We will do that.
For those of you that are participating remotely, you'll see on the bottom of your screen something that says interpretation. That gives you the choice of listening to the language, to the floor here, or have simultaneous translation in French or English. So as an Anglophone, you probably want it on English, and then you'll get the voice of the interpreter when French is being spoken here.
Thank you.
Donc, je vais...
So shall I start over, Ms. Wilson? Yes. Right. What I was saying was this. In listening to the 3 groups representing the police here today, I seem to understand that the decriminalization of simple possession has had more positive impacts than negative impacts in this fight against the opioid and toxic drug crisis. Do you agree with that? Just a quick answer is all I need. I don't necessarily want you to outline all the details. I have other questions, but I just want to know if you agree with that statement.
I do not agree with that statement.
Okay.
And I would concur with Deputy Chief Wilson.
Mr. McDonald,
Mr. McDonald?
pourriez-vous?
Yes, I agree with Deputy Chief Wilson.
Vous n'êtes pas d'accord avec l'énoncé qui consiste à dire
And so you do not agree that decriminalization has brought about more positive impacts than negative impacts? Have I understood you correctly? And if so, could you please explain why?
Thank you. Yes, I don't agree with that. I would say there are positive results from decriminalization, as Deputy Chief Wilson has indicated, in terms of the number of people charged with criminal offenses and attempts to divert them away from the criminal justice system. However, we do note challenges in public consumption and ancillary criminal behavior.
OK, mais par rapport à la crise des surdoses.
But I'm talking about the overdose crisis and our ability to save lives and the ability to help accompany individuals and find them assistance. Do you feel that this should become an offense again, that it should be criminalized again? Is that what you're saying, Mr. McDonald? That simple possession should be criminalized again?
No, that's not what I'm saying. What I am saying is that decriminalization has not come without its challenges. So, for example, since decriminalization, our overdose deaths have not decreased in the province of British Columbia, nor have our overdose rates. We are still in the early stages. There's still much work to be done. But in terms of finite numbers of overdose deaths and overdose rates, those have not decreased since decriminalization. What has decreased is the number of charges with respect to simple possession. And we have increased our number of referrals and working with other agencies to divert people from a pathway of criminality to health.
OK. Vous dites dans votre présentation.
You said in your opening remarks that there are other challenges you're facing. For example, the diversion of safe supply to an illicit supply. But you're saying that collaboration continues with authorities and you're trying to better understand the problem. So what are you doing to better understand the problem? What stage are you at? Because a little further on, you say that you are developing training and educational tools. So I'm supposing that you must understand the problem now if you're at the stage of developing training tools. Could you expand on that, please?
Yes, thank you for the question. So some of the challenge with identifying safer supply drugs once they are diverted into the criminal marketplace is first we have to identify them. If they're out of their packaging, they're often not stamped as safe supply drugs. So we want to be sure that when we locate prescribed drugs that we believe to be safe supply, they are properly identified, because we do not want to stigmatize legitimate users of those drugs. So in many cases, safer supply drugs may be diverted from one area through the criminal element to a broader marketplace. So you've likely seen the news releases on Prince George and perhaps Campbell River, areas where we have made criminal seizures of safer supply drugs. But it's important to note that we have to train our officers in how to identify those drugs should they not be in the accompanying packaging, or should they not be identified right at the first outset as safer supply drugs, because we want to make sure that we're accurate. So when we do seize safe supply drugs, we do engage with health authorities in the province of British Columbia so that we can better track and identify those drugs and identify where they've come from.
Thank you, Mr. McDonald.
Comment
Merci,
vous expliquez
Monsieur Thériault.
ces saisies de drogue sécuritaire?
I'm sorry, your time is up, Mr. Thériault.
Mr. Johns, please, for 6 minutes.
Well, thank you. Thank you all for your testimony, and especially for your service to the people of our communities and our country. Ms. Wilson, you're the Deputy Chief Constable with the Vancouver Police Department, but you've also had a long career in law enforcement with lots of frontline experience, including walking the beat in the downtown east side, Vancouver. We know that drug use is a long-standing issue and that things have become increasingly complex in the recent years. Can you tell us about what has changed over the last 10 years or so with illicit drugs and the opioid epidemic from a policing perspective?
The most significant thing that's changed over the last number of years is the toxicity of the illicit drugs. It's only in the last 10 years or so that we're seeing the incredible toxicity in the drug supply. That's really what's contributing to overdose deaths. And unfortunately, initiatives like decriminalization are not going to change that fact. It's this drug supply that is killing people, not that they're using too much, but that the drug supply itself is toxic. And I'd say that's the single largest change that I've seen in my 25-year policing career.
The BC Chiefs of Police and the Canadian Association of Chiefs of Police both came out with policy statements supporting decriminalization, supporting a safer supply to replace the toxic drugs that you're talking about. Now, there's been a lot of media focus around diversion lately. The BC RCMP recently issued a statement saying that the presence of confirmed safer supply prescriptions are in the minority of drug seizures. Maybe you can tell me, is diversion of prescribed medications and drug seizures something new, something that started with the introduction of pharmaceutical alternatives? And also, from a policing perspective, what drugs are having the biggest impact in driving the toxic drug overdose crisis?
So diversion of prescription medication is nothing new. 25 years ago, when I walked the beat in the downtown east side, there was always somebody standing at Main and Hastings offering, T3s, for example. So the issue of diversion is not new. I think the devil's in the details when we're talking about diversion, because there's certainly diversion of prescription medication, which is different, but inclusive of diversion of safe supply medication. And then, of course, there is what is a much more pressing issue to me as a police leader, the matter of counterfeit pills that are produced and can be produced in very, very, very large quantities. And the problem with that is they look exactly like prescription pills. So the possibility of someone dying as a result of taking what they think is a diverted prescription are actually quite high, because we don't know what's actually contained in those counterfeit pills. And from an organized crime perspective, that can be really scaled up. Unlike diverted prescriptions or diverted safe supply, which is a very limited, more of a street level phenomenon, the issue of counterfeit prescription medication is capable of really scaling up, and that's a huge issue. So certainly that's one thing. And when it comes to what is the most deadly part of our drug supply, it's fentanyl, absolutely. In 85% of overdose deaths, it's attributable to fentanyl, and then cocaine, and then methadone. So what we don't see, at least not in Vancouver, and I can't speak for the whole province on this, despite the fact that I am here in my capacity as president of the British Columbia Association of Chiefs of Police. I don't know the nuances in all communities across the province, but in Vancouver, that's where our focus is, because that's what people are dying from, according to the coroner's data. They're not dying from diverted safe supply. They're not actually dying from diverted prescription medication. They're dying from fentanyl, coke, meth. And that's where we really focus our enforcement efforts.
And would you say that the deadly fentanyl is easier to access than the diverted hydromorphone on the street?
I would say it's more prolific. There's more of it. In British Columbia, we have somewhere between 4,500 and 5,000 people who are on a bona fide safe supply program. So it's a limited amount of drugs to be diverted. And the same goes with prescription medication. It's quite labor intensive.
I really appreciate that. And we're here. We've seen rates in Alberta skyrocket. They've gone up 17% of overdose deaths. Saskatchewan, 23%. Both provinces without a safe supply program. BC rates have plateaued, it looks like. We're seeing about 46 deaths per 100,000 in BC, 44 in Alberta. In Alberta, half of the people that have died between the ages of 39 years old have died from toxic drugs. So would you believe that safer supply, and you hear that that information that's being put out there is the driving cause of deaths, toxic drug deaths in British Columbia, or do you believe that's disinformation?
We know that that's not the case. Now, having said that, diversion is an important issue. It's something we're always watching very closely, but we know from coroner's data that that is not what's killing people in British Columbia.
Do you believe that we should reinstate the expert task force on substance use that Mike Chair used to co-chair, your colleague?
Yes, I think that would be helpful.
Thank you, Mr. Johns. Next, Mr. Doherty, please, for 5 minutes.
Mr. Chair, I want to first preface my comments today with thanking those from our police forces that are our witnesses here for your service and your sacrifice. It is greatly appreciated. Deputy Commissioner McDonald, have you or anyone else at the RCMP been asked by anyone in the BC NDP government or federal Liberal government from the beginning of 2023 to today, including elected officials, staff of elected officials, department staff, or anyone, to not speak publicly about safe supply related drug seizures?
Thank you for the question. No.
Deputy Commissioner McDonald, in April, a memo was leaked from your division, E Division, to all frontline personnel as well as all detachments in British Columbia, essentially saying that it is an election year and that there are so-called hot button topics such as safe supply, and it is they have asked for, you have asked, or your office has asked for frontline officers as well as detachments to not comment publicly on these hot button political issues.
I'm sorry, would you want me to respond? Is there a question there?
Is that, where did that come from, and what concern was there that caused that gag order to be issued?
Well, I think it's important. First off, yes, that memo was directed by our communications director here in the province. The police have a very important role to play in many instances of public safety issues, particularly in the illicit drug challenge that we face in British Columbia. And it's very important that police are objective in this. So any comments that may be perceived to either support or not support any one particular party can have a negative impact on the objective role of the police. Our job is to get out the facts.
I appreciate that, sir. But whether it's an election year or not, do you believe that British Columbians and indeed Canadians deserve to know the truth about criminal activity in their communities?
They absolutely do, and we share that information regularly, as you've seen from many news releases recently about seizures of illicit drugs and some cases safe supply drugs.
With all due respect, the memo came out after both Prince George released a statement regarding safe supply and ongoing investigations, as well as Campbell River. We know that Victoria, Nanaimo, Kamloops, Kelowna are all seeing the same. Doesn't it seem that there would appear, at least publicly, that there's a concern from E Division and those above that again, that communities in our province deserve to know the truth about what's going on in our region?
I completely agree that the communities deserve to know the truth, and it's our responsibility to provide the facts and the evidence to the communities when we see that occur. Sir,
the definition of widespread is distributed over a wide region or occurring in many places or among many persons or individuals. Assistant Commissioner John Brewer has said, he's on the record as saying there's currently no evidence to support a widespread diversion of safer supply drugs in the illicit market in BC and or Canada. We know from testimony as well as from reports of these investigations and these arrests that is taking place in Prince George, Campbell River, Victoria, Nanaimo, Kamloops, Kelowna, and indeed First Nations across our area and in Alberta. Would that not, just by the very nature of all those communities, would that not, common sense would say that that is a widespread problem?
Thank you for the question. I think it's important to provide the context for that statement from Assistant Commissioner Brewer. It was in response at that time to statements made that we had safer supply diverted to most communities in British Columbia and outside the province. At present, we do not have evidence to suggest that safer supply has been diverted outside of British Columbia. We do see, and I agree with you, that we've seen it in some of the communities that you've listed. Those are also the same communities that have a predominant criminal illicit drug market and organized crime groups in them. And as we identify them, we're addressing them, but we have not seen it everywhere. However, I will say it is an emerging concern, and it's something we're following very closely.
Would your frontline officers, the 6,800 frontline officers in British Columbia, would they agree with that statement that there is no evidence to support widespread diversion? They're seeing it every day on the ground.
Again, thank you for the question. I would say it depends on the community in which they serve, because we're not seeing it in every community. We are seeing it in some communities.
Thank you, Mr. McDonald and Mr. Doherty. Next, Dr. Pawlowski, please, for 5 minutes.
Thank you all. Let me start off by saying I think I, like all of us here, our sympathies are overwhelmingly with all those who've lost people under the drug crisis. However, I want to talk about a different aspect of this problem. A few months ago, I was downtown in a bar here in Ottawa. Not that I do that very often, but a couple of my colleagues that I met up with, one was assaulted as he was going to the bar. Another one was threatened. About within a month of that also, I was returning down Wellington Street from downtown to Rideau Centre. My son, who's 15, was coming after me. It was nighttime, and there was someone out in the middle of the streets yelling and screaming, kind of accosting cars. I asked them, the parliamentary police said this to them, and they said, "Oh, he's someone we know. Don't worry about him." My son didn't know that, so I waited for him because I didn't want him to have to face some kind of crazy person accosting him in the street. There's certainly the perception by a lot of Canadians that a lot of downtown cores are basically out of control. And certainly there's also the perception that around places like safe supply, safe injection sites, that things are worse, that there are people openly stoned in the street, people are getting CPR performed on them in the street, there's needles around in the street, there's excrement in the street. Now, one of the pillars of the Swiss approach to their drug problem is trying to decrease harm to society. I would note that that is not part of the Canadian approach. Does that need to be more part of the approach? And I'm asking this to the representatives of the police out there. Do you agree that this is a problem? Do you agree, for a lot of Canadians who aren't involved with drugs, that they are increasingly unhappy with society and downtown cores which are this way? Do you want to do more about this? And if you do want to do more about this, what do you need in order to better address this situation? So let me start with, let me start with the RCMP, and then we'll go on from there.
Thank you for your question. I would note that in our experience, one of the success factors that is required for decriminalization is public support. And I think when you're faced with situations where, as we've seen and experienced in our communities, we hear from our communities, where public consumption in some places may lead to other members of the public feeling at risk or threatened or vulnerable to street-level crime, as you've spoken about, it does present a challenge because it not only creates situations where criminal activity can occur, but it also puts a stigma on people who use drugs that may or may not be engaged in that type of activity. And if we don't have public support moving forward, decriminalization and societal acceptance of that will be an uphill battle.
Could I ask the two other heads of police chiefs? Same question.
Sure, I can address that question. It's not lost on me that your example was in Toronto, where there is actually no decriminalization. So I'm happy to comment on our decriminalization experience here in British Columbia as it relates to public consumption, because I couldn't agree more with Deputy Commissioner McDonald that the matter of public consumption on our streets is something that we were very, very concerned about before the application went in for the Section 56 exemption and continue to be concerned about to this day. In fact, all of the concerns that we had have been realized. We've had some really concerning examples of public consumption, despite the fact that, in my experience, the vast majority of people who use drugs have no interest in doing so in front of children, for example, or in manners that I think are problematic. You know, and I have to give our provincial government their credit for doing everything they could to come up with a Public Consumption Act. And unfortunately, that act has been prevented from going into force as a result of an interlocutory injunction that was issued by our Chief Justice of the BC Supreme Court. So, you know, there have been efforts to address that. It would have been nice to have that matter addressed prior to the submission of the request for the Section 56 exemption. And it is an ongoing challenge here in British Columbia for sure.
Okay. Thank you. Ms. Huggins, I'm not sure if you wanted in on that. That is Dr. Pelosi's time, but if you want 30 seconds to offer your perspective, go ahead.
I'd say the only thing that I would add, thank you for the additional time, is that the CACP Special Purpose Committee on Decriminalization has reconvened, and this is one of the issues that will be incorporated. We are taking another look at decriminalization based on the experiences that we've learned in the last few years. So I think that it is one of the priorities that will be in that report. Thank you for the time.
Thank you. Mr. Thériault, 2 minutes et demi.
Mr. Thériault, you have 2.5 minutes. Thank you. I have a question for the RCMP. One of the pillars of the national strategy is to be able to enforce the law. So I'd like to know what tools you need in order to be more effective in enforcing the law. For example, when it comes to seizures, when it comes to tackling criminal groups and the illicit supply.
That's for you, Mr. McDonald, I believe. Or Mr. Ing.
Yes, through the chair, and thank you for your question. Related to tools for law enforcement, as per decriminalization, we are not seizing quantities below 2.5 grams. We are not pursuing investigations on those offenses that we would have prior to decriminalization. Having said that, we are now needing tools to target the ones that are actually selling and trafficking the illicit drugs to users, and ultimately the ones that are actually producing the toxic drugs that are sadly causing the deaths. I do note that there are precursors utilized to manufacture fentanyl and methamphetamines and other opioids. A number of these precursors are currently unregulated, meaning that they're legal to possess and utilize, and the police do not have the powers currently to seize or to investigate the possession of these chemicals. So it would be great for law enforcement if there was an effort made to start to schedule and regulate these types of chemicals, to allow and permit and give authority to the police to seize these chemicals to prevent the manufacture of the illicit substances. Thank you.
That's all the time you have, Mr. Thériault.
For 2.5 minutes.
Thank you. We know the expert task force came back with some unanimous recommendations, and it was chaired by Mike Serra, the former president of the Canadian Association of Chiefs of Police. Sorry, And their recommendations were unequivocally unanimous and supported to stop criminalizing people who use substances, provide a safer supply of substances of people that use substances that require it, to scale up prevention, education, and treatment on demand. Those were all policies that were, very similar to what Portugal had done. And right now we're hearing this campaign about the diversion as the dominant factor for driving the toxic drug crisis. Do you believe that this diversion in terms of conversation around the diversion of safer supply substances is actually causing more harm by slowing down the pace of addressing the real root causes and the real problems and us responding to this drug crisis? Ms. Wilson, I'll let you start.
Well, I certainly think that for us here in Vancouver, as I said earlier, we focus on what is doing the most harm. And we know that diverted safe supply, diverted prescription medications are not what's killing people. And also, when you consider the volume or the potential volume to scale up diverted prescriptions, diverted safe supply, it pales in comparison to what organized crime are doing in terms of fentanyl production, importation, exportation. Those are really where we focus our efforts here in Vancouver. And I think it's important that we continue to use our finite resources to focus in on those areas that are, and those individuals, those groups that are doing the most harm. So although I think diversion is important, we need to keep an eye on it. It has been around for a very, very long time. And in my mind, when we look at the overdose deaths and when we look at the scalability, there are other areas that I would focus in on in terms of the individuals and groups who are doing the most harm.
Donald, just a yes or no in terms of, do you think it's causing more harm, this conversation about diversion versus scaling up our response?
I think both conversations are important.
Okay. Thank you very much, Mr. Johns. Next, back to Mr. Doherty for 5 minutes.
Deputy Commissioner McDonald, have organized crimes incorporated safe supply pharmaceuticals into their trafficking operations? Yes or no?
Yes.
Corporal Jennifer Cooper of the Prince George RCMP said the following: we have noted an alarming trend over the last year in the amount of prescription drugs located during drug trafficking investigations, as well as organized crime groups are actively involved in the redistribution of safe supply. Do you agree with those statements?
Yes, our organized crime groups are trafficking not only illicit substances, but any prescription drugs that they can get their hands on.
We know of an recent investigation in Prince George, where organized crime individuals literally stood outside of pharmacies and bought or collected the safe supply from those that were receiving it. Is this true?
Yes.
Is from what you're hearing from frontline officers, in your opinion, has decriminalization contributed to an increase in general street disorder and illicit drug use in the public?
From our experience in our communities, I'm not certain you can draw the correlation that decriminalization has contributed to an increased disorder. What we do see, as we've noted, both myself and the other police officials on this panel have noticed, is that the public consumption of illicit substances is presenting increasing challenges for law enforcement to deal with, and it's becoming an increasing concern in our communities.
Understand that the nature of your comments and those of others in downplaying the seriousness of the diversion problem or denying that there's a problem at all goes against every detachment and municipality fighting for more resources for policing. Assistant Commissioner Ng just said we need the tools. So when we're fighting for those municipalities, when municipalities are asking for more resources, when you have statements such as Assistant Commissioner Brewer's or indeed yours, it kind of flies in the face of those of us that are trying and fighting for you to get the tools and the resources to do your job. Do you understand that?
Well, I would disagree in the sense that we're not downplaying diversion. We are identifying where it's occurring, how it's occurring, and the fact that it's occurring in addition to the other illicit substances and drugs that our organized crime groups are trafficking in. We're targeting those groups, and we have a commitment to provide accurate and timely information to the public and to government officials so that they too are aware of the problem.
On March 11th, the statement on safer supply, the seizure of prescription drugs such as narcotics and opioids that are no longer in the possession of the prescribed owner is something the police have had to deal with on many occasions. Again, it goes back to there's currently no evidence to support a widespread diversion of safer supply drugs in the illicit market in BC or Canada. Deputy Commissioner McDonald, I'm going to have to disagree with you. When your frontline officers and your detachments are actually producing and presenting more evidence to that. It's frustrating when you have folks that are fighting for you and fighting for your frontline officers, and I know that they disagree with the public statements. And then you have comments such as this. It would appear that the RCMP and indeed the BC Chiefs of Police are covering for the government in an election year on an issue that's politically bad for them. Can you at least agree with me that that would, that's exactly how your comments and those of some of your officers would be taken?
No, I'm sorry, I completely disagree with that.
Well, we're going to have to agree to disagree on that. How many more communities need to report diversion of so-called safe supply before it crosses the threshold of widespread? How much more time? All right. Ms. Wilson, are all of the BC Chiefs of Police on side with decrim and safe supply? Or is there some that are concerned and want to push pause on this experiment?
Well, I can certainly say we've expressed our significant concerns with decriminalization. There's no question about that. I think one thing all chiefs across the province agree on is that we do not want to throw people in jail simply by virtue of their personal drug use. Beyond that, as we've learned, the devil is in the details. We have been flagging the issue of public consumption since prior to the submission of the exemption request. And what's happened is exactly what we predicted would happen. We're satisfied that the province has tried to address that through the Public Consumption Act, unfortunately unsuccessfully to this point. And back to the matter of diversion, the reality is that there are 7 people a day dying in British Columbia as a result of the toxic drug crisis, and they are not dying as a result of prescription diverted medication. They are dying because of the poisonous drug supply that is on our streets.
Thank you, Ms. Wilson. Dr. Hanley, please, for 5 minutes.
Thank you very much. And Deputy Chief Wilson, thanks for emphasizing that last point. I continue to be puzzled by the emphasis from my colleagues on diversion, which, as you have stated, and others, is a problem that needs to be addressed, but which is not killing Canadians. It's our toxic illicit drug supply that is killing Canadians. I do have a couple of short questions for you. One is my colleague Dr. Pawlowski described what it's like to walk around downtown Ottawa here, and certainly when I walk home every day I encounter similar circumstances. But this is not an area where we have a decriminalized approach. So can you just talk about the correlation? I know there is a correlation with public acceptance, and that this is a serious issue to be addressed. But can you talk about the correlation between decriminalization and public safety and public consumption?
Absolutely. So prior to decriminalization, if someone was using drugs in a problematic circumstance, for example, at a playground or at a bus shelter or at a beach, Police were able to, community members were able to call 911, police were able to attend, and were able to address that circumstance. The vast majority of drug users, and I've done 3 tours of duty in the downtown east side, I can assure you, have no interest in using drugs around youth and children, for example. However, when those circumstances do arise, it's very, very important that police have the tools to address it. And in the wake of decriminalization, there are many of those locations where we have absolutely no authority to address that problematic drug use because the person appears to be in possession of less than 2.5 grams, and they are not in a place that is an exception to the exemption. We had 3 exceptions added to the exemption last year in September, which was helpful. So that included skate parks, playgrounds, and there was a few other exceptions that were added. So we now have 9 exceptions to the exemption. But the reality is there are still a number of other circumstances where the public have significant concerns about problematic drug use. And when that happens, if it's not in a place that's an exception to the exemption, there's nothing police can do. It is not a police matter in the absence of any other criminal behavior. So if you have somebody who's with their family at the beach and there's a person next to them smoking crack cocaine, it's not a police matter because a beach currently is not an exception to the exemption. That's what we were hoping to have addressed through the Public Consumption Act. The thing I really liked about the act was it did not further criminalize people by virtue of their drug use. Rather, it required police to ask people to leave, and it was the refusal to leave that would have introduced criminal sanctions, as in obstruct. So, I thought it was a really good balance between what we had previously under the CDSA and also, respecting the rights of people who use drugs, but also ensuring that people in our community feel safe. And I think that's a very, very important issue.
Thank you. Thank you. So is this a failure of implementation or a flaw in implementation, you might say, or is decriminalization in itself a faulty principle?
I think we all agree that we do not want to criminalize people when they've got, by virtue of their personal drug use. Those days are gone. We want to support a health-led approach. The problem is, as I said earlier, the devil's in the details. And those details were not, and quite frankly, police warnings were not heeded in the first instance. And so we've got situations, for example, where technically people could use under 2.5 grams of a variety of illicit substances in a licensed establishment as long as the licensee allowed them to, and they weren't contravening any smoking bylaws, for example. That opens up a whole can of worms for police, potentially. If you have a nefarious business owner who's has a licensed establishment, technically you could have a situation where there's an 18-year-old who could use cocaine in a licensed establishment but can't order a beer, assuming that the licensee allowed them to do that. So these are all things that we raised prior to decriminalization taking effect that we don't feel were adequately addressed. However, we strongly support the notion of not trying to arrest ourselves out of this crisis. That is not going to save lives. And in fact, it does quite a bit of harm when you've got somebody who has a significant addiction that they need medical help with, or they, need support. The last thing they need is to be introduced into the criminal justice system.
Okay. Thank you. Ms. Goodridge, please, for 5 minutes.
Thank you, Mr. Chair, and thanks again to the witnesses for this. I guess my first question to Ms. Wilson is, what other exceptions to the exemption would you like to see?
Personally, based on this journey that I've been on from the very beginning, in fact, initially with the City of Vancouver and then with the province, I would like to see additional exceptions in places like beaches, bus shelters, within a certain distance of residential buildings, businesses, the entrance of a workplace, for example, sports fields, parks, places where families and youth could reasonably be expected to be.
Do you think that we should have an exemption for drug use in hospitals?
Absolutely. Like one of the things that we talked about was private and semi-private places. Like, for example, in Tim Hortons or in a McDonald's. Hospitals are another great example. When we consulted with our health authority here in Vancouver, they have been dealing with the matter of people having drugs in their possession for many, many, many years, whether it be going into an ambulance or into a hospital. However, the fact is that, once again, when those conditions in a hospital become problematic, there's nothing the police can do about it.
And it's really unfortunate that you guys don't have the tools to be able to do what you need to do to keep our communities safe and people away from having new addictions. My question is kind of simple. Why didn't the Vancouver police arrest the Drug Users Liberation Front when they handed out about $3,000 worth of drugs in front of the Vancouver Police Department in 2021?
So there's all sorts of considerations that go into a decision such as that, including Crown's likelihood of approving charges. And, not to say that we don't collect evidence with respect to that incident and others similar, but we do have a number of things that we have to consider, including Crown's directive with respect to their drug policy. So there's a number of considerations, some of which remain quite confidential, and I only mean that from a policing perspective. We employ all sorts of techniques, including covert ones that we simply wouldn't talk about in public setting.
So my question is to Deputy Commissioner McDonald. Has the inability to seize less than 2.5 grams of fentanyl or any substance under BC's decriminalization had a negative impact on your ability to get deadly fentanyl off the streets?
Thank you for your question. The permitted exemption for personal possession presents some challenges for law enforcement when we're conducting investigations in terms of, starting at the grassroots level and leading up to those that are trafficking. We have modified our investigative techniques. We've conducted significant amount of training. So it took a while for law enforcement to adapt our approach and principles, but we haven't seen a decrease in trafficking investigations or trafficking charges in British Columbia as a result.
Decriminalization has been successful in BC so far?
I'm sorry, the first part of your question cut out. Could you please repeat it?
Do you think decriminalization has been successful in BC so far?
I think aspects of decriminalization have been successful when you look at the stigma attached to people that previously may have been arrested for personal possession and then diverted into the criminal justice system. I think we've seen positive impacts there. I think we still have a long way to go, as you've heard all the police leaders speak on the aspects of public consumption, and we're encouraged by the province of British Columbia's attempt to amend the legislation, and we're hoping for success in that matter.
I would like to move a motion that given a leaked memo from British Columbia Health Network states, and I quote, "Staff are not to search or seize patients' drugs or weapons with blades less than 4 inches long or restrict visitors who bring them drugs for personal use. And this applies to anyone in possession of 2.5 grams or less of fentanyl, heroin, cocaine, methamphetamines, or MDMA. And B, the ongoing situation at Victoria General Hospital in British Columbia, where illicit drugs are regularly consumed by patients at Victoria General Hospital, exposing patients, including pregnant women at the maternity ward and healthcare workers, to the risks of inhaling toxic substances, coming into contact with illicit powders, and facing harm from intoxicated patients. C, that the result of dangerous drug decriminalization policies, the committee report its support of the victims of this situation, including nurses and pregnant women, in its condemnation of policies that allow for dangerous drug use in hospitals, and that the committee calls the following witnesses: the Minister of Mental Health and Addictions and Associate Minister of Health, Health Canada officials for no less than 2 hours, the Victoria Police Department representatives, and British Columbia Nurses Union representatives. Mr. Chair, I think through the last little bit of testimony we've had here, it has become increasingly clear that there are some very serious issues when it comes to decriminalization, and we are seeing major impacts. And we've even heard from Vancouver police specifically that there are exceptions to the exemption and that this has not been put into play in a way that is preserving public safety. And so I think it is absolutely incumbent on us as the Health Committee to study and to look into the direct implications that it's having in our hospitals. I can't imagine, in reading some of these stories, some of the horrific pieces that we've had to see, and pregnant women being told that are nurses, or nursing moms that are nurses being told that perhaps they don't want to breastfeed their child because there are concerns regarding the drug use in hospitals. And the drug use is so open that people are wearing gas masks. So I just share this. I hope that we can approve this motion and get back to the witnesses. Thank you.
Thank you, Ms. Goodrich. The motion is in order. It's clearly on the topic that is being discussed as part of this study. In fact, there was reference to it already today. So the motion is in order. The debate is on the motion. I recognize Dr. Hanley.
I just wanted to briefly say there is obviously this attests to a problem that indeed exists. However, want to maximize our time from hearing from our witnesses, which is why we're here today. I also have concerns about the scope of the motion as relates to a provincial jurisdiction. So in that spirit, I would like to ask you to adjourn debate.
Motion to adjourn debate is a dilatory motion that is not debatable. We must go straight to a vote. All those in favor of the debate being adjourned, please raise your hand. 1, 2, 3, 4, 5, 6. All those opposed? 1, 2, 3, 4. The debate is therefore adjourned. You have 37 seconds remaining on the clock. Ms. Goodrich.
Thank you, Mr. Chair. So I guess my next question is, how can we, do you think that decriminalization should continue in its pilot project for the next 2 years? Deputy Commissioner McDonald.
Thank you for the question. Well, the decriminalization is scheduled to continue for the next 2 years. I would like to see, as I'm sure my police colleagues would like to see, more exemptions with respect to public consumption so that we can deal with those critical issues. I think if we can get those exemptions in place, then we have a better chance of seeing the true impact of decriminalization and helping those that are struggling with addiction and diverting them away from the criminal justice path into a health path.
Thank you, Mr. McDonald. Next, we're going to go to Ms. Sidhu, please, for 5 minutes.
Thank you, Mr. Chair, and thank you all the witnesses for being here. My question goes to Ms. Wilson. You said we need a multi-level approach to dealing with the opiate crisis. We know that the realities in BC are different from Ontario, because I'm from Ontario, and that many communities across the country are impacted. We also know that it's important to respect the jurisdiction of our provinces and territories and work together with them. With that being said, is there anything you would like to see in terms of our work with the provinces and territories to fight with the organized crime responsible for this deadly supply killing, which is killing Canadians? Ms. Wilson, you can answer that.
So I certainly think that there's, if it's the case that British Columbia does not successfully have the Public Consumption Act, if we're not able to bring it into force, the other option, of course, is to add additional exceptions to the Health Canada exemption. And so that's something that, although we are hoping that the province will exhaust the possibility of bringing the Public Consumption Act into force, because, quite frankly, it's less intrusive when it comes to people who are using drugs. Because, as I said earlier, there's a requirement that police would simply ask people to leave, and they leave whole. No ticket, they leave with their drugs, but they do have to move on. And it's the refusal to do so that would become a problem. As opposed to exceptions in the exemption, which means that the exemption does not apply in those particular places. So we revert back to the Controlled Drugs and Substances Act, which is criminalization. So if there was an advocacy piece in the absence of that provincial legislation being successfully brought in, I would hope that we would have support to work with Health Canada to add additional exceptions to the exemption.
My question is that, how can we work together to support our frontline law enforcement officers to responding to this crisis? Beside this jurisdiction question, is there any other, you said Health Canada, but how can, can you just elaborate on that?
Well, certainly we have a number of things that we do to try and assist our frontline officers who, as you make a very good point. Like at the end of the day, they are the ones who are dealing with the tragedy associated to the toxic drug crisis in terms of frontline response, along with, of course, all of the people who are impacted, the loved ones, family, friends of people who are dying. So anything that we can do to support those members, and that includes naloxone kits, being issued naloxone kits. But quite frankly, I think the most frustrating thing for our members right now is seeing situations where they do not have the tools to adequately respond. Our frontline members at the end of the day, they want to be able to deal with these problematic circumstances of public consumption. And I think that would be the single best way to support them, is to give them those tools so that they would be able to do their jobs in those circumstances where there's community concerns about problematic drug use.
And I have one other question. In your testimony, you said 85% death is from fentanyl. Is there any education campaign need to be addressed with the other organizations who is working on the ground?
So that's a great question. I always talk about decriminalization as being one tiny piece of a much, much larger puzzle. And in order to put that puzzle together and see what the picture is, we need education, increased prevention. We also need some harm reduction services and, things like our members carrying naloxone kits and safe injection sites. But really, it's a multifaceted approach to this problem that includes, safe supply initiatives. But any one thing on its own is not going to be effective. But I can't tell you how supportive police in this province are when it comes to increased education, increased prevention, and also increase in health services such as treatment on demand.
Thank you, Ms. Sidhu. Mr. Thériault, pour...
Mr. Thériault, you have 2.5 minutes. Thank you. And my question is for Ms. Huggins. Earlier on, you said we're facing a public health crisis and that there has to be a comprehensive approach taking into account social health determinants. Now, this afternoon, there's been talk about the connection between decriminalization, possession, and consumption in public areas. So if we want to achieve harm reduction, how can we find solutions to these kinds of things? For example, safe consumption sites or supervised consumption sites. Are they inadequate? Are they not enough? Are they not attractive enough to those individuals who are choosing to use elsewhere instead of at the site? Do these individuals have enough housing, let's say, or do they have enough shelters? When they're going into a McDonald's, for example, to use, or into a hospital to use, it may be because they have nowhere else to go. So could you address those issues, please? Could you speak about this comprehensive approach based on health determinants? social health determinants?
Thank you very much for the question. I think that you're very much correct that, and I think that Deputy Chief Wilson actually mentioned it. It is an all-encompassing approach. So you mentioned things like why aren't individuals using the supervised injection sites? I think the role of a community approach that includes health and justice and police is really to do that kind of assessment, not only to understand what you need in your community, but what those individuals may want or need at a different time in with whatever issue they are dealing with. So there are quite a number of resources that we have identified as, having an impact on an adequate health response. And so housing has been mentioned, the supervised injection sites, location. So I think that the issue is that we need to all work together, and that's about the collaboration between health, police, social services to determine what is required and what do those individuals in that community need.
Thank you, Ms. Huggins. Merci, Mr. Thériault. Mr. Johns.
Thank you, Mr. Thériault.
This is a question for Ms. Wilson. In terms of diversion of opioids, can you tell me about what's also happening with opioids prescribed or chronic pain and other conditions that you're seeing on the street in terms of what's prevalent and what's changing?
Yeah, so we see both. I mean, there's no question about that. We know that of patients who are prescribed hydromorphone, for example, about 20% of them are in a bona fide safe supply program. About 80% of them are prescribed for pain outside of addiction issues. We also know that about 50% of the pills that we come across that are hydromorphone can indeed be attributed to safe supply. And, that's just in recognition of the fact that someone who's on a bona fide safe supply program has a more regular, significant supply of hydromorphone. What my biggest concern when it comes to pills is the number of organized crime groups that are actually producing counterfeit pills. Because I saw a photo of this just last week, and you could not distinguish the counterfeit pill from the real prescription pill. And the problem is we have no idea what's in the counterfeit pill, and it could absolutely be deadly.
Thank you so much. Deputy Commissioner McDonald, you've got an exemplary career. Do you find it offensive or insulting that it might be suggested that you're misleading in your testimony here at this committee, that it might be influenced by a provincial election?
Thank you for the question. No, I don't take offense. These are critical issues that have to be discussed. I understand the concern that police agencies could be directed or influenced, but I don't take exception to that, and I'm more than willing to answer those questions.
We have not had a summit on the toxic drug crisis, yet we've had a summit on the auto theft issue. Do you believe that it's deserved to have a national summit on the toxic drug crisis and a First Minister's meeting? And do you believe that we should reinstate the expert task force on substance use?
I'm sorry, was that directed towards me?
Ms. Huggins. Ms. Huggins.
Ms. Huggins.
Thank you.
Sorry, I didn't hear the beginning part of the question. Thank you for the question. I think that there is a lot of value in having that expert task force reconvened. I think that now that we are we've had the experience of decriminalization in British Columbia, there are lots of things that the whole country can learn, and we need to learn from it. So the task force is definitely needed, and I think that you will see lots of support from it across the country. I also think that a national summit is important. These are issues that affect every corner of the country, and there needs to be that exchange. You hear from Dr. Day, very different approach in Alberta. We hear from BC the different issues that are facing law enforcement with, public unrest. So definitely a summit is important and will help us in the future to determine what elements need to be included in any type of approach.
Thank you, Ms. Huggins.
Thank you.
Dr. Ellis, please, for 5 minutes.
Well, thanks very much, Chair, and thanks for everyone for being here today. Dr. Day, we talked a bit about the amounts of drugs that have been decriminalized. And we throw around this amount of 2.5 grams of fentanyl. I've spoken about it in the committee here. I'm a former physician, but you're a current addiction specialist. Maybe it means more coming from you to put that in perspective as to how deadly that amount of fentanyl actually is.
Thanks for that question. I think I'll put it this way, Dr. Ellis. There are published case reports in the literature of people dying of overdose from accidental administration of 3 milligrams of hydromorphone in a hospital setting. There are multiple cases of that, and that's why it's a high-risk medication and why we go to so much effort to label things morphine versus hydromorphone. Hydromorphone is extremely potent and could kill a person with no trouble if they don't have opioid tolerance. When we look at fentanyl, which is 50 times more potent than morphine, and then you look at the number of grams that a person could hold, that certainly is an amount that could easily kill one or more people.
Well, thanks very much for that, Dr. Day. And to me, it would seem slightly ridiculous to allow people to have 2.5 grams of fentanyl when routinely, perhaps in the emergency room, if we were going to use it for a procedure to reduce a dislocated shoulder, we might use 200 micrograms. Is that a fair statement?
That's absolutely correct.
Thank you very much for that. The criminal operations officer, Mr. Ng, you talked a bit about precursor chemicals and the difficulty having them listed as being illegal in Canada. Is that something that law enforcement regularly communicates to the Liberal government to say we need better action and quicker action on that?
Yes, thank you for your question. And through the chair, we have communicated through the Law and Amendments Committee and a number of other committees to government that we'd like to advocate for the scheduling of those precursors. And so far, I think it's still a work in progress.
Thank you very much. And through you, Chair, again to you, sir. Do you have any idea how long that's been in the process now?
It's been brought to my attention for over 2 years.
So what you're telling this committee is that we know that there are precursor chemicals out there used to make fentanyl, carfentanil, sufentanil, et cetera, incredibly potent opioids that are killing people on the street, part of this so-called toxic drug supply, that this government could actually make illegal, and for 2 years they've refused to do so.
Through the chair, I can't comment on the refusal part, but I can comment on the time it's taken to continue to advocate for it.
So it's not happened in 2 years, basically.
Yes.
Thank you for that. I appreciate it. Deputy Chief Wilson, we talked a bit about the drugs that are on the street these days, and clearly 8 milligram tablets of hydromorphone are incredibly potent. There's a plethora of them out there on the street, perhaps one of the drugs of choice nowadays. We know that, again, 8 milligrams is significant because that is what is being issued in safe supply regimes, approximately 30 tablets at a time, I understand. Can you comment a bit of what you've seen about the price of hydromorphone on the street?
I'm sorry, I'm not up to speed with respect to the price of hydromorphone. I know that it's very, very cheap, but I also know it's not hydromorphone that is killing people in our province.
That's a fair statement. That being said, you talked a bit about your tour of duty in the downtown east side previously, which I thought was an unusual comment, given you were serving in a metro Canadian city. Why did you characterize it as a tour of duty?
In the Vancouver Police Department, we commonly talk about different areas that we work as a tour of duty. So I've done 3 in the downtown east side. I did a tour of duty in professional standards. It's just a common police phrase.
No, certainly I have a military background, so I would not comment of serving in a downtown metro of Vancouver a tour of duty, but I understand you have a different way of referring to things, so thank you for that. Deputy Commissioner McDonald, do you have any idea about the street prices of hydromorphone in BC in general?
Thank you for the question. We do have specifics that we could provide at a later date. I do understand, and what I'm told, is the price of hydromorphone in the illicit market has gone down significantly in the last while.
Thank you.
If you could table those with the committee, we'd be very appreciative if you could look at the prices over time. That would be excellent. Thank you.
Thank you, Dr. Ellis. Mr. Johari, please, for 5 minutes.
Thank you, Mr. Chair, and thank you to all our witnesses for your important testimony and the services you provide to keep our community safe. Deputy Chief Wilson, you talked about education campaign and how important it could be, and you also talked about how sophisticated these criminals are getting into making the illicit drugs very similar into the safe supply. What kind of education campaign can all the various levels of government with the law enforcement as well as support organization work with each other, specifically in the areas hard hit with illicit drugs?
So I think there's lots of options or opportunities for collaboration with respect to education. Just to clarify, I was talking about organized crime creating what appeared to be pills that look like prescription medication, not necessarily safe supply, but a whole myriad of prescription medication. But, you know, I honestly think when it comes to education, a lot of it should really be health-led. You know, police play a role in education. There's absolutely no question about it. And I can certainly speak for the VPD. We have countless initiatives here where we work on getting out and educating youth in particular about the perils of drug use, whether it's be through our schools, community centers, all sorts of programs that we run. But I would really like to see health take the lead when it comes to educating our youth and our public about the perils of drug use. And, you know, I think that's a really important thing for us to consider anytime we're thinking about these initiatives. If we truly want this to be a health-led approach, then, you know, we do need health to take the lead when it comes to things like education, prevention, treatment on demand. Yeah, not to say there's not a role for police in that, but I feel like we've been doing that for many, many years.
I want to go to the Chief Commissioner McDonald. So the issue that we've talked about a number of different issues, whether it's safe supply, whether it's safe consumption site, whether it's illicit drugs that's killing people, all of those. But bottom line is these drugs are getting into Canada. What are some of the programs to enforce the border, is being rolled out in even blocking these illicit drugs getting into our country?
Thank you for the question. I'll comment from a federal policing perspective, where that is one of the top priorities for our federal policing units to combat transnational organized crime, whether that be at land borders, whether it be at ports, whether it be through air service, at the marine. We've worked countlessly with partners all over the world to combat primarily, I would say, pharmaceuticals coming in or the pre-circular materials coming in. We've had great success, but there is much more work to be done. Part of it is intelligence sharing. We have excellent relationships with our partners. Part of it is joint forces operations. We work with the Canadian Border Service agencies. We work with United States partners and others to combat that, and we continue to do so.
Actually, we have one of the largest land border with the U.S. Can you give me some idea around the degree of let's say the challenge that we have in managing that border, that big border, or is that an issue?
Well, certainly we do have one of the largest undefended or open land borders in the world, but we also have excellent relationships with the U.S. authorities and our partners. So it does present challenges. We clearly have large commercial transportation networks for legitimate goods that transit throughout North America. Those also present opportunities for organized crime elements to manipulate those transportation routes to import illicit goods. But we have had great success. We continue to do so. It presents challenges, as you're aware of, but we've increased our technological aspects in combating those crimes. We've increased our intelligent aspects and our joint enforcement aspects as well.
10 seconds. Where internationally are we getting most of these drugs being imported into Canada?
If we're talking our precursor materials that are predominantly used for fentanyl production, they'd be coming from Asia and India and South America.
Thank you.
Okay, thank you, Mr. Johari. To our panel of witnesses, this almost never happens. We've now completed 3 full rounds of questions, and we have just under 10 minutes left on the clock. So I'm going to propose 2 minutes for each of the parties to finish up our time. Is everyone okay to proceed in that fashion? So if you can stay with us for another 10 minutes, we're going to go now to Dr. Ellis for 2 minutes.
Thanks, Chair. To you, Deputy Chief Wilson, if I might. You talk about multiple exceptions to the exemption in the decriminalization experiment. It would appear to me that there wouldn't be many other public places for people to use drugs if that your wish were to come true, which would allow people to take back the downtowns that they would like to visit, like Dr. Pawlowski. Is that the aim of what your comments were?
So recognizing that part of the challenge here is that when people use alone, they are more likely to die, because if they're not with other people, there's no chance for intervention. Having said that, I think it's really important for us to balance the safety and feelings of safety by all community members with the rights of people who use drugs and our efforts to keep them safe. So yes, I do think we should expand the locations in public spaces where people will not be allowed to use drugs.
Thank you very much, Deputy Chief Wilson. To you, Dr. Day, how does the federal addiction policy impact your incredibly innovative way of delivering your policies in Alberta with respect to drug addiction and treatment? Is it positive or is it negative?
There we go. So thank you for that question. I think that Alberta does not feel particularly well supported in its policies around the response to the drug crisis. I think that there are things that we would appreciate happening. So, for example, one of the greatest predictors of a person staying in recovery, if they've gone through treatment and they're on evidence-based treatment medications, is employment. Are there opportunities for the federal government to support employers to take on people in an early sustained recovery? Are there opportunities for the unemployment insurance system, for example, to support a person who is in active addiction, who's lost their job, to go and receive supplemental funds so that they can successfully attend treatment and recover their life and go back to work? There are lots of things that we could be talking about that I don't think are controversial, that I think could have broad support in the public to support recovery for our population.
Thank you, Dr. Day and Dr. Ellis. Dr. Pawlowski, please, for 2 minutes.
No, having previously brought up the fact that I think public consumption is detrimental to society in many ways, us as a committee, if we're going to make recommendations, like, what do we do about it? If we allow and we decriminalize possession, where are they supposed to do it? When people are homeless and they are users, Are they supposed to go in their tents and quietly die there so we can't see them? Like, what is your solution? And I really mean this, and if you don't have a solution now, think about it. Do we put the safe injection sites like out of the public domain? Do we patrol around there, or how do we do it so that we let people who are addicts use it but not have them be in public because of the detrimental effects? Anyone who wants to answer?
Question for me?
Sure.
Oh,
Why don't
okay.
you start with you?
Sure, I can jump in. I mean, I think you really speak to the importance of having services such as overdose prevention sites readily available to people in community. We have 12 of them here in Vancouver, but now we recognize that 60% of the people who are dying through inhalation, not injection. So it's a question of pivoting and being able to accommodate those individuals so that they are able to use safely if that's what they choose to do. And that's why those services like safe consumption sites are so incredibly important.
If anyone else wants to add their 2 cents, sir, go ahead.
Yeah, perhaps I could add to Deputy Wilson's comments. I think people like choice. They like to have options when it comes to anything in life. And when it comes to consumption of drugs, if there's only one option that doesn't suit them, then they're going to go where it suits them. That may be public consumption. So as noted in some of our supervised consumption sites or overdose prevention sites, there's no inhalation rooms or ability to inhale. We find that most of our overdose deaths are related to fentanyl and related to inhalation. So we need to provide spaces, I think, that would allow for that, but it can't be a space where someone has to take a bus for 4 kilometers and go across the city to find that. Need to be readily available, but there also need to be multiple options in terms of treatment, in terms of counseling, in terms of safer places. And I think it deserves a conversation so that we don't force people into one pathway that may or may not work for them.
Thank you, Dr. Pawlowski. Mr. McDonald, suite Monsieur Thériault pour 2 minutes.
Mr. Thériault, you have 2 minutes. My question is for Deputy Commissioner McDonald. During the seizure of drugs in Prince George or Campbell River, the Attorney General in BC said there was no evidence of diversion in British Columbia, which was supported by the RCMP. Would you corroborate what he said a month later? And if so, why? And if not, why as well? What would need to be done to avoid these kinds of seizures, or rather this kind of diversion? What are your solutions to diversion?
Thank you for the question. I'm not aware of the Attorney General's comment. I do know that the province of British Columbia, they acknowledge that there is diversion of safer supply drugs, just as there is with other prescribed drugs. In the case of Prince George, we have direct evidence that has led to criminal charges identifying safer supply drugs that have been diverted, that were seized in conjunction with a multitude of other illicit substances. I think moving forward in terms of how we deal with the diversion of drugs, whether they be safer supply or subscribed or other prescribed drugs, first off, we have to be well educated to be able to identify them properly. Once we determine that they may be diverted safer supply drugs, we need to know where they have been diverted from, if that wasn't evident in the investigation. If it's coming from a particular outlet, we need to work with our health authorities to find out where the cracks are and how those drugs are being diverted. If they're being transported by a criminal network from elsewhere in the province, we need to know where they originated from. And then we can work with the health authorities to identify problematic users that may be diverting their safer supply and trading it up in the illicit drug market.
Mais vous avez aucune réponse aux questions que vous avez.
And what, you don't know where it's coming from? At this point in time, you have no idea where it's coming from?
Thank you for the question. To clarify, in some contexts, we know exactly where it's coming from because the investigation has borne that out through direct observations. In many cases, some of the drugs are being seized in their original packaging. Oftentimes, however, the identifying information, such as the original customer's name or location, have been scratched out of those bottles, and there's no tracing element that is put into safer supply drugs. So if those drugs are located outside of a package or have been repackaged, say in a plastic bag, we will not be able to determine what their initial origin was.
Thank you. Final questions will come from Mr. Johns, please. 2 minutes.
Deputy Commissioner McDonald, you were asked earlier about the prices of hydromorphone and that you cited that they've dropped significantly. Can you talk about the prices of deadly concentrated toxic fentanyl, benzos, tranquilizer? Has the prices of those on the street also dropped and plummeted significantly?
Thank you for your question. Since we saw I would say, the initial influx of fentanyl into the market here in British Columbia some years ago, it has become cheaper. It is the drug of choice. Unfortunately, it is easily accessible, and that is why, in my opinion, it is such a killer. Because you have a cheap drug that is readily available that in small amounts can result in death.
It's down. The fentanyl is driving the price down of all drugs.
I'm sorry, could you repeat that, please?
The toxic fentanyl is driving the price down of all drugs. Would you say that?
Thank you for your question. I don't know if I could say that it's driving the price down of all drugs. It's just that the fentanyl is so prevalent in the market, it's becoming cheaper and cheaper, and it is by far the drug of choice amongst users that are attracted to opioids.
Deputy Chief Wilson, you heard from Deputy Commissioner McDonald about the need for safe consumption sites to allow inhalation and to be closer to people. Can you talk about the impact of increased homelessness in major cities contributing to public drug consumption? And would you say that adding more safe consumption sites and allowing inhalation would help counter some of the concerns around decriminalization and that policy in British Columbia?
Absolutely, and it's a great example of the need to have a multifaceted approach to this. It's not just about decrim, it's not just about safe supply, it's not just about education, treatment, prevention. It's about everything together, and increasing the number of safe injection sites, safe consumption sites, where people can inhale as opposed to just injecting, I think is a very, very important piece of that. And when you overlay our increases in homelessness, I think it's really important to provide individuals with safe places where they can use drugs. We know that that's what many people are choosing to do in any event. And, I heard recently from a person who's actually was down in the downtown east side for 20 years and has now been clean for 11 years. It took him literally dozens of times in treatment, and he's only alive today because of the intervention of harm reduction and safe supply services. And so I think that this is a very, very complex issue. It's really important that we take this approach that covers off all different sets of circumstances. Ideally, we provide prevention and education so that people don't start using in the first place. But we also have to address the fact that there are some folks who are entrenched and who are using, and we want to try and keep them alive. And then there's sort of everyone in between. So I think that's probably my largest comment about today, that we really do need a multifaceted approach, and no one approach is better or worse than the other. They're all really necessary.
I want to thank all of our witnesses for being with us today. The level of professionalism and the conciseness of your answers really, really is appreciated, and we appreciate what you all do to keep us safe every day. Thanks for being with us. Is it the will of the committee to adjourn the meeting? Yes, sir. We're adjourned.
you.